Dr. Jim here, everyone, and I'm really excited to give you a presentation about case acceptance. And we're going to be focused on implants, but this will apply to any complex dentistry that you're doing in your office. Back in 2001, I started a practice based pretty much on implant dentistry. About 80% of what I was doing were implant surgery and implant prosthodontics. And I was there for 15 years. I started from 0 patients. And when I left, it was a thriving practice with about 2,000 patients. Before that, in a different background, different venue, I founded and helped build a general dentistry practice in a small rural town in Horicon, Wisconsin. It was a nice little town of about 3,800 people. And pretty much the dentistry I did there was general dentistry. And then a couple of years ago, I retired from full-time practice. And I presently work up in Eagle River, Wisconsin for Dr. Scott Biotti. I place implants for him. That's all I do now. And at the same time, I started a teaching and coaching business on implant dentistry. And so I help dentists chairside to go through procedures that are new to them. And I'm also involved in helping them build, organize, and market dental implant practice. So if you add it all up, I've been a dentist for 37 years now. Here's my contact information if anybody wants to get a hold of me after the seminar. It's dramstad@gmail.com. My phone number is 920-210-2149. And let's kind of frame it a little. Implant dentistry is really a growing part of dentistry. There's a lot of interesting things going on that are working in our favor. There's fewer dentists out there. There's a lot of people retiring, and the population is growing faster than the number of dentists. Along with that, a lot of people are becoming more aware of dental implants as a treatment. So we're in kind of a perfect storm. Another interesting demographic, and it really applied to my practice in Sun Prairie, back in 1988, now I started in 1980, but back in 1988, 12% of practice income came from people over the age of 60, and now it's up to, I believe, 64%. These people are in really a lot of need of comprehensive dentistry. They've had a lot of fillings, they've had a lot of crowns, they've got missing teeth, they've had root canals. So the probability of needing implant dentistry just keeps going up and up. The American Academy of Implant Dentistry has got a little fact sheet on their website. It's almost stunning to me, but there are 35 million Americans that are missing all their teeth in one or both jaws. 15 million people in the U.S. have crown and bridge replacements. And another little unknown fact, I think, is that general dentists now are placing the majority of implants in this country. Just want to frame that for you. There's a lot of opportunity out there. I hope you're doing dental implants. I'm going to talk about what the goals are here. So I would like to introduce you to a system for successful stress-free presentations. We're going to talk about identifying patients that have high dental needs. We're going to discover what the patient's emotional handicaps and triggers are that are caused by the disease. We're going to talk about facilitating patients to envision what's possible. We're going to talk about staff training, and I do want to cover the concept of budget and how to discuss finances and money with people. This is a flow diagram of how I handle patients in my own dental practice. Here's another reference for you. Dr. Paul Homley was one of the first people to get me to understand that people purchase on emotion, and he's got a great book called Making It Easy for Patients to Say Yes. It's kind of a cookbook and maybe a little simplistic, but it gives you a great outline of what this webinar covers too. You can get that at www.paulhomley.com. Before you can present cases to people, you got to have patients that need and want implant dentistry. It may not be completely relevant, but I did want to just talk a little bit about marketing. I just would like the audience to know, it may surprise you, but I typically spent 8 to 10% of my gross collections on marketing. I did start out at about 4 to 5% and found that as I increased my spending on marketing, I had more and more implant patients to the point that I couldn't really handle any more than I was getting. So I would vary this percentage, but not uncommon for me to spend that amount of money. And when you're marketing, you want to establish a brand, a logo. You need to figure out what your little niche in the marketplace is. You want to stay focused and be consistent in your marketing. Of course, you need to determine your budget. And I would highly recommend that you not try to do things on your own. You're better off hiring a professional firm to do marketing for you. Here are some of the methods that I used for marketing: TV, radio, newspaper, website, pay-per-click. I had a study club, social media. All of these things went into the marketing that I had when I was in Sun Prairie. And would like you to know, this was directed at people really over the age of 50 and kind of to the baby boomer generation. Your demographic is going to be an older patient crowd when it comes to implant dentistry. So here's basically an outline now of the presentation. We're going to talk about the initial phone call, what we did to identify patients of high need, and how we determined their readiness for treatment and how we scheduled them. And then you can see the other bullet points. We're going to talk about comprehensive exams and identifying handicaps and motivators. We will be touching on the important concept of budget and how to discuss money. And then right at the end of the presentation here, we're going to tie it all together. Okay, so let's say you got successful marketing going on and you got a steady stream of people calling you. You're going to start to get phone calls. The first thing I want you to think about is what your conversion rate to an appointment is on phone calls. A lot of times when I'm consulting, I get out there, maybe 1 out of every 3 calls is being converted to an appointment. And if you're going to be successful and use your marketing dollars to their fullest advantage, you're going to want to have a conversion rate of 50 to 60% or higher. And that means that over half the people that call in are being scheduled for an appointment to see you. What I mean by that is you have to be organized, you have to have a well thought out process, and your staff really needs to know how to handle a phone call. Here's a picture of these two gals were the people I had at the front desk, and they really knew their stuff. They could tell you up and down how long it would take for appointments, what the general cost of treatment was. They were very attuned to the patient's emotional triggers, and they were excellent at getting people in that had high dental needs. A good way to think of it is that we want to be advocates for our patients. So we're trying to do what's best for them, trying to listen to what are the things that are bothering them, why did they call us. Just important to really be basically a friend to the patient when they call in. Okay, so when people call in, we had some what I call identifying questions. I think there were 2 really important questions. Really the second bullet point was usually the one that we asked first, and we would usually ask people how they heard about us, because this would give us an idea of what marketing was working for us. So sometimes people would say TV, or they saw the website, they maybe saw an article in the paper. We would always mark down and keep track of how people heard about us so that we knew how to direct our marketing dollars. Typically after that, one of the more important questions, if they aren't volunteering a lot of information, is to ask them how many missing teeth they have. This will really give you an idea about whether or not this patient has been seeing dentists regularly or not, and it often leads to a conversation about some of the things that are bothering them. Additionally, you could ask them, when was the last time you saw a dentist? How often are they going? And also, very importantly, are they having any urgent dental problems, or are they in any dental pain? If the patient was calling and they were just a general dentistry patient, they had been going every 6 months, they didn't have any missing teeth, we would appoint them into the hygiene schedule. But if they were somebody who was missing teeth, they were having pain, maybe they read on our website that we do implant dentistry and they were interested in it, then we would schedule them to see the doctor. And so we treated people differently. The high needs patients, we spent a lot more time with. Here's a sample handout for you on the telephone call slip. It just goes over some of the things I just talked about. You notice at the bottom it says disposition. really when people would call, they either went into the hygiene schedule, they might have come in for a free consultation, they might have been scheduled for a complete exam, maybe they just didn't want to come in at all. If they didn't want to come in at all, we'd try to get an email or an address. We would build basically a marketing list of people we could send implant information to. Yeah, all you have to do is when I get to the end here, again, you can download this and feel free to use it as you see fit. Kind of digress a little bit. One of the things that we always tried to do, if somebody had an emergency, we would stop the process and ask them if they felt like they needed to be seen and how much problem or how much pain they were in. We would get them in ASAP and take care of them. Often I would just try to fit them in the same day they called. It just demonstrates that you care, and it helps you develop a connection to the patient. And it was a great practice builder. If you do get emergencies, and these people are usually high-need patients, it really helps to take care of them as fast as you can. It just helps to build confidence with the patient that you're thinking about them and caring about them. What we would try to do, identify patients of high dental needs and then determine their readiness for treatment. Now, some of the patients have been online, they've researched treatment options, they know a lot about implants already or other forms of treatment. They have an idea what they'd like to spend, and they're ready and eager to go. They're ready to start treatment. If you get a patient like that, don't put roadblocks in their way. Let's get them in the door as fast as you can. I would recommend really that you never make eager to go patient wait more than a week or two. And I always say sooner is better. Typically in our office, we would block out time for new patients. And I also worked with a dental assistant who was a hygienist. And so sometimes we could start doing a complete exam on people by rearranging the schedule and delegating some of the accumulation of information to the hygienist. Really worked out good, but don't make them wait. The other patients that call, they may know a lot or they may not know much at all, but they've heard about implants, and these people, we try to get them in. If they're not quite ready for a complete exam, they got a lot of questions, what we would try to do is answer as many questions as we could, but the goal was to get them scheduled with the doctor. And the front desk would always say, you know, the dentist, our doctor is the expert. He's best able to answer your questions, or she's best able to answer your questions. And then we would have them come in for what we call a free consult. And I'll describe that to you in a second here. So yes, it's free. I never charge for it. What we would do is we'd have people come in and fill out a quick little history, and then we would take a look at what it was that was bothering them. I would come in the room, take a little look in their mouth, and have a short discussion of what their treatments are and possibly discuss finances, especially if they had a lot of questions about that. And I would always tell people there's really only 4 treatment options. One is to do nothing and let things go as they are. The other 3 options are something completely removable that's not hooked to anything, basically a denture. Then there's what I would call semi-hooked. That would be like a partial. It's removable, but it's hooked to something, either teeth or implants. And then there's fixed dentistry. That would be either bridges or implants or what you and I would call a fixed hybrid. And I would tell people that the comfort level goes up as the appliance becomes more fixed, but also so does the cost go up. That would just give people an idea of what's possible, and if they were interested, then they ended up being scheduled for a nice, thorough, comprehensive exam. So just to kind of summarize it, at this point we have 2 types of patients scheduled. One is the real eager, ready-to-go patient, and the other is a patient who's very interested in treatment, but they're a little uncertain yet, and maybe they're not sure what kind of treatment they want to pursue. So now back to the outline of the presentation. We've talked about the initial phone call. We've got them scheduled for the comprehensive exam, and so now we're going to start to gather the information that's needed to develop a treatment plan, and at the same time we're going to talk about handicap and emotional motivators. So here's a little summary of that. When I say comprehensive exam, I mean comprehensive exam because people of high needs have very complex treatment. We want to make sure that we've got all the information and data that we need to do a complete diagnosis. So, we're doing the x-rays, we may have a pan, a full mouth, or we might have a cone beam. We're doing a periodontal exam. We're doing a medical history. All my patients I did photography on before and after. And of course, an examination of their occlusion. So as dentists, that's really what we do is we're really focused on the technical aspect of treatment, but we don't want to forget to explore the emotional side of treatment and why the patient came to see us in the first place. And of course, we're wondering what they are hoping to get out of a treatment plan and how it can give them a better quality of life. There's two, what I call, very important factors that are going to affect the successful case presentation. The first one are what the patient's motivators are and what their handicap is. And then we also want them to envision what the treatment is going to do to impact their quality of life. And then later in the presentation here, I'm going to talk again about this concept of budget. And we're going to get to that quite quickly here. And these are what I call the two most important factors that will affect the outcome of patient acceptance. Exploring handicap. So I think of this as a disability, and the handicap is the emotional consequence of the disability. So for example, somebody is missing teeth, they're having difficulty chewing. The handicap is that they're missing out on really good foods that they like to eat, such as like a steak or an apple or something like that. Or maybe they're missing teeth, their disability is the missing teeth, their handicap may be that they're embarrassed by the way they look. We want to identify these emotional disabilities, these handicaps, and help the patient get to an envisioned future. So here are the typical motivators. Difficulty chewing, constantly in pain, embarrassed by their appearance. I always try to identify life events. Are they getting divorced, married, new job? They came into inheritance and now they have money to do treatment. And then there are significant others, their friends and family that are impacted by their disease. So like a good example might be a patient who has a denture that they can't wear and the granddaughter says, "Grandma, where are your teeth?" The disability is the missing teeth, the handicap is the embarrassment. So we want to be alert to these motivators because these are the things that are going to lead patients to accept treatment. So again, just to emphasize that, we want to focus on the benefits of the treatment plan and what it's going to do to impact the patient's quality of life. If you do that, you're going to increase your acceptance rate. I'm going to expand on this handicap concept a little bit. It's more than identifying the negative things that are going on. Let's talk about what I call facilitation and motivational interviewing. There are the positive things to treatment, so I would like people to think about, and we ask a lot of questions on if you remove the handicap, what would that do for them? So it's a process that allows us to explore the patient's thoughts and helps them to envision a better future. So for example, let's say somebody's having difficulty chewing and we're going to make them implant fixed bridge work. Well, the disability is they can't eat. The question I would ask them is, if we do make fixed teeth for you, what would that do for you? It gives the patient an opportunity to think about if they had treatment and if they had teeth, how is that going to change the quality of their life? Facilitation is a really complex skill. I always felt that I was pretty good at that, but over the years I've received a lot of training, and I'll talk to you about that in a second. So here's kind of an outline of the facilitation process. Somebody comes into your office, they've got a disability, that's the dental condition, and then how is that dental condition handicapping their life and how is it affecting it? And then we want to talk about what we can do for treatment that will remove that disability and what would that do for them, how would that help them? And then kind of bring them back to the beginning again and see if we can get them to take some action steps like scheduling treatment, basically. I do have another handout for you. It's called Motivational Interviewing, and it really talks about the steps in facilitating a conversation about the patient's disabilities and how you can motivate people to accept treatment. You'll find that in your handouts. It's really a great article. I'm also going to promote these people, Terry Goss and Janice Dupre. I've known them for 15 years, and in my mind, they're experts at communication. I'm sure there are other people out there that can do the same thing and can do a great job of it, but I have used these two to improve my communication skills and help me learn how to facilitate and motivate patients. So I include them here because I just want you to know I didn't just develop all this stuff on my own. I've needed help, like everybody does, to become a better communicator. We're going to digress a little bit and talk about why we do dental implants and what the benefits are. What I do want to do is just kind of review with you dental implants and what they do for people. So what are the benefits? Well, number one, when you place an implant into somebody's jaw, the stimulation of that implant helps preserve the bone and keeps it from deteriorating and resorbing away. Consequently, your face maintains a natural shape and presentation, and you avoid that sunken in, denture look that we often see when people have a closed vertical dimension and they lose their muscle tone. Additionally, what I like about implants are you're not chopping down other teeth to make a bridge. The implant stands on its own, and quite often I used to just cringe making a bridge in the old days because some of these teeth were in great shape and really did not need to be ground down other than to serve as an abutment for a bridge. Last but not least, implants just provide a whole avenue of creating comfort for a patient. Now, it could be a denture like this locator denture you see in your picture. It could, so it eliminates a poor fit, gum irritation, all of that. Very superior in comfort, reliability, but it doesn't have to be just a denture. It could be a bridge, it could be an all-on-4 fixed hybrid denture. There are so many ways implants can help people. And let's just kind of look at the list and summarize that completely. We have the implant pros and cons. We're not grinding down healthy teeth. There's a lot of studies on this, but implants do way better over time than bridges do. You don't have trouble with decay. You don't have to worry about the bridge abutment popping loose and then the tooth decaying underneath there and you lose another tooth. Basically, if you're making a bridge over 3 units, you probably should be considering doing implants instead. What do we have? Implants are the closest thing that we have to something that functions like a normal tooth. The cons are, well, it's more expensive, probably. Maybe not over the life of the implant, but initially the cost is a little higher. But so is the service, and maybe the process takes a little longer because you got to wait for implants to heal. There's also the slight chance that the implant won't integrate, but if you get one like that, usually placing another, you'll get integration. There's very few people that can't have an implant and wouldn't benefit by them. So basically, I'm just kind of recovering this with you because I just want you to have a lot of confidence and excitement about recommending implants to your patients. So now we're going to get back again to the outline of the presentation and talk about budget. I find this concept really helpful, not only just with implant dentistry, but any kind of dentistry you're doing in your office. And I hope you use this concept because it'll make your job and your staff's job a lot easier when it comes to discussing finances with your patients. If you read the header, you'll see that all is in a different color. Once you've satisfied and answered all of the patient's concerns, and I stress all, then the final barrier to treatment is often finances, or at least we need to talk about them. The reason I say all is you need to, or I always tried to answer every concern a patient had because I didn't want them distracted from the financing topic. Here you have my 3 dental assistants, 2 hygienists and 1 dental assistant going, oh no, we're going to talk about the money. Okay, so I'm just going to read this to you. This is how I used to do things, and I can tell you this did not work for me. I'm just going to read it to you. What I considered the traditional model of case presentation that I had been taught I had been taught to dazzle my patients with a comprehensive exam and then educate them to death about the technical aspects of my dentistry. And then at the final case presentation, I would give them a treatment plan I felt was best, sometimes without regard to what they wanted or needed. After that, I would basically surprise them with the cost of treatment because I had no idea of what they could afford. And then I would sit back and wait for their response. And I don't know about you, but I wasn't very successful doing that. And on top of it, then I've created an adversarial relationship in an environment where my patient may be forced to say no because they didn't have the money to do the treatment plan that I was recommending to them. And I've wasted their time and my time. And I learned real quickly that a lot of them walked out the door and never came back. And so I knew very shortly after I started my complex dentistry practice I needed to change. So here's how I did start to talk about money. And I did it, sometimes we would start this conversation with the initial phone call. We sure talked about it when they were there for the complex comprehensive exam or the free consultation. But the question I would always ask people is, have you thought about your budget for dental treatment and what you can afford? I was surprised by how straightforward a lot of patients were. And of course, when I asked them about budget, I would tell them that I was really good at staying within their budget and that I was going to work hard to develop a plan that they could afford. So people were relaxed and were straightforward about the money conversation. And you'd be surprised how many people had a pretty big budget in their mind and were willing to spend a considerable sum of money. Sometimes you'd get an answer that allowed you to do just about anything you wanted to do. But at any rate, we're just letting the patient know that we're working in their best interest and we're going to try to develop a plan that works best for them. And I'm going to talk about a few techniques with the money conversation. First off, I just want to tell everybody out there, this is not a crass conversation. We're not attempting, I never attempted to diagnose a patient's wallet. I just wanted to avoid a confrontation with them over money, and I wanted to help them discover a treatment plan that they could afford. I always framed the discussion about money as a benefit to the patient that I'm working on, their behalf. It would just build a bridge between us when it came to talking about money. When a patient tells you what their stated budget is for treatment and you don't feel that it's adequate to do the job, don't take their first statement about budget as the final answer. Let me give you an example. Let's say in the initial conversation with a patient, I've talked to them and they want fixed dentistry. They don't want a denture. They don't want something that's coming in and out of their mouth. And yet the budget they tell me isn't going to allow them to get fixed dentistry. Well, then what I would do is ask them if they would stretch that budget to a higher amount. And sometimes people would. So sometimes somebody would say, I can only spend $5,000 or I can only spend $10,000. And then I would have an honest exchange with them about, well, it's just not going to get you to the kind of dentistry that you want to do. Is there any way that you could stretch your budget to a higher amount? And sometimes patients would rearrange their priorities and take away spending in some areas of their life and put it to their dentistry. So one of the techniques would be to just sit there and ask them if they can stretch that budget. Another question I would ask people, and I would often be caught off guard, so I would say to somebody, what's your budget? And they'd say $10,000. In the beginning, I found out that some people meant $10,000 a year, and they could do that for 2 years or 3 years or 4 years. And so when somebody gives you a budget, ask them if that's their complete final budget or can they spend more additional money in the future. And you'd be surprised at how much people are willing to do over time. So maybe we can do a better treatment for them if we phase it in over several years. When I did that, though, I always made sure the patient knew their responsibility to finish and complete treatment. Otherwise, the case can fall apart in the middle of treatment because they don't follow through. There's a couple techniques there for you, but really treatment is this conversation about money is kind of a win-win. You know, you're not in stress. You're not arguing with the patient about money. They are deciding for themselves what they want to spend. And just takes a lot of, it just makes it way easier for you. And you shouldn't be afraid to discuss money. Most patients want to talk to you about money. They're just afraid to tell you no. And so if you open up the door to them, they're going to be usually quite straightforward with you. Let's tie this all together now. And I want to talk about financing treatment. So we've talked about the initial phone call. We've talked about the comprehensive exam. We've identified handicaps and emotional motivators. We've discussed the concept of budget and how to discuss money with patients. And so now let's, like I say, let's tie it all together. So I like to say success is really near. We've pretty much put all the elements together that we need to do a final consultation. And the final consultation really should be more an appointment that wraps up everything, because we've already answered all the patient's questions. We've developed the plan that they're interested in. We know they can afford it because we discussed the budget with them. And so typically in our office, the consultation appointment's more about wrapping up the loose ends and scheduling appointments, how many. Maybe we're answering some questions on the mechanics and the length of time for treatment. And the final consult should not be difficult, and it definitely shouldn't be adversarial if you've used all the techniques that I've talked about. So the consultation appointment goes from like, oh, are we going to succeed, to let's get started. Let's talk about the mechanics of the financing just a little bit. So let's digress. I always presented dental insurance to patients as a subsidy to treatment, and you know, most people have a maximum of $1,000 or $1,500. Maybe they got a maximum of $2,000. Implant dentistry is way more expensive than that. And I would just tell people that dental insurance was designed for healthy people who only needed maybe cleanings, x-rays, maybe a filling here and there, maybe a crown here and there. But it really wasn't meant to take care of people with your really high needs. So I'd say insurance is wonderful. I didn't want people feel bad about insurance, but it is really meant to subsidize the cost of treatment. So I did a little groundwork for you guys out there, and I highly recommend using financing companies in your office, and I recommend that you don't finance treatment yourself. You just you can end up in a real adversarial role with people. I'd rather delegate this off to companies that regularly finance care. So now another disclaimer, I have used some of these companies. I have not received any money, compensation, benefits, nothing. And this is by no means a complete list. I did summarize some of the companies that I know about. I've got a phone number there for you, and there's going to be a little bit of information about the plan. And here's just some of the handouts. This final screen here, well, second to final screen, I believe, shows you some of the handouts that are available. I would encourage all of you to invest time and effort in your what I call your soft skills. Get really good at communicating, get really good at listening, get really good at facilitating and motivating people. I'll stay on the line to answer questions. Thank you very much. Let's go to the question screen here. Okay, so first question is, what is an emotional trigger? What I call an emotional trigger is what may have caused them to call us in the first place, is motivating them for treatment. So a good example of an emotional trigger might be somebody's got a wedding coming up, Mike, and they want to look good for the wedding, and they're embarrassed by the way the teeth look. And so that's their emotional trigger and their motivation for calling. And so your treatment's going to need to address that. The initial preliminary viewing, slide 21, what unit of time are you suggesting? If you're talking about the the free consult, I myself like to not schedule more than 10, 20 minutes for that, 20 minutes at the most. But I have to tell you, a lot of those conversations went on a long time, and basically I would go out of the room and tell the patient that my assistant would be able to answer their questions. We had it set up that I had an extra assistant, or you could be a treatment coordinator, that they could sit there with the patient. And they might sit with the patient for an hour, Lana. Hope that helps you. But as far as doctor time goes, you really can't have your doctor spending more than 10, 20 minutes, especially if you have a lot of new patients coming in from your marketing. Do you present what your options are for possible failures? Yes, I do, George. I think that's really like what we would call informed consent. My philosophy was, with big cases and the amount of money that people are spending, I would just tell people, I'm going to take care of you until you're satisfied. And I worked super, super hard to make sure that people were satisfied with what I did. If we had an implant failure, they already knew that that was a possibility, and we would just redo it. And I didn't charge them for it. Those things were built into the overall fee. But yeah, for informed consent, I mean, you really need to tell people what the pitfalls of treatment are. Next question, well, that's from one of my buddies out there. She says, do you present the cost of treatment, or did your staff do this? Oh my gosh, I would just run from a financial conversation. But as I got better with discussing budget and I became more confident, I really didn't mind talking about the cost of treatment. Although I have to tell you, that's really not a best use of my time, and so typically the staff did that. But if I was in a situation where I needed to give a patient an immediate direct answer on how much a treatment would cost, I did do that. Good question. So this is my own opinion, and there may be other opinions out there, but in my hands, I'll say it that way, I have not found many implants to be very successful. And presently, the only mini implants I do are implants that don't have a real firm attachment. But I would tell the audience, nowadays the distinction between minis and regular implants is really small, because you can get a 3mm implant now that in the old days would be almost considered a mini. So I really don't do too many minis anymore. Okay, Kevin asks, do you use marketing companies specific to dentistry and examples? And yeah, Kevin, I'll answer that real directly for you. Yes, I like using a marketing company that's specific to dentistry. I'll give you a name, and again, I have not received any money. I haven't received any benefits for mentioning them, but I use a company called Progressive out of Florida. You can email me, again, at dramstadt@gmail.com, and I will send you the phone number and contact person that you can get a hold of. Typically, a well-run case presentation, good conversion on the phone, you're probably looking at spending about $850 per implant patient that you get, not per implant, but per implant patient. Which financing company is your favorite? I really don't have one. I mean, I've used Care Credit quite a bit, Springstone. I don't really have a favorite, and you should investigate them because they all have different methods of financing. Some of them are non-recourse and others are recourse. Whatever you're comfortable with, but check them all out. Melissa asks, how do you handle implant failures or retreats? I basically just do them over again, Melissa, and I don't really charge people for that unless, and not always, but I may have somebody who's an uncontrolled diabetic or smokers. You're going to have a higher failure rate in my mind. I might charge them for like a restocking fee. But if I get a failure to integrate on the initial treatment, which doesn't happen a lot, then I just replace it. But your success rate, your osseointegration rate should be 95% or higher. And if you're dropping down around that 80% mark or lower, which I do see, then there's something wrong with your technique, because implants are very successful and most of the time integrate. So is there a first consult for free, a second appointment for records, and a third for consult? Yeah, that only happens though, Keith, if the patient isn't quite ready for treatment. So that can be short-circuited, and somebody who's really eager for treatment basically just gets an appointment for records and then a consultation appointment. There are a lot of people that just want to talk to you and discover who you are, and then yes, then there's 3 appointments. That may seem like a lot, but it's really pretty necessary because there's a lot of liability and responsibilities to these. But I can tell you this, Keith, we don't stretch it out. If I got a free consult and a records appointment and a consult, I really try to get that all done within a week or 2. We really try to accelerate that. Let's see. Keith asks again, is there a charge for the records and the second consultation? I don't charge for the consultation, but there is a charge for the records. You know, they are paying for x-rays. I don't really charge for photos. Sometimes I would charge for study models. I always felt that I didn't want to nickel and dime people on the records appointments because, I mean, some of these people, I think the largest case I ever did was $82,000. To sit there and haggle with people over $50 up or down on a consult appointment, a records appointment, you really don't want to do that. You're going to benefit so much from having a great patient who's going to do thousands of dollars worth of dental work with you. Mark asks about a fantastic team. Was there profit sharing? Good question, Mark. I was very open with my staff about how we were doing and how much money we were making, and I just kind of had a share of the pie philosophy, and if I was doing better, I would bonus people and just give them extra cash. And so there wasn't set profit sharing incentive. Everybody on the team felt like they were part of a big effort. I thought really pretty highly paid, but they deserved every penny of it, I'll tell you that. What about senior citizen discount questions they always ask? I had a cash-only practice, other than we provided financing through financing companies. So I did not accept insurance payments. The patients paid us, and the insurance check went to the patient. With senior citizens and with everybody, if they paid cash, I would give them a 5% discount, and so I guess you'd call that our senior citizen discount. Jason says, good lecture, Jim. Can you expand on the financing aspect for the patients? You know, really, when we were using the financing companies, after we got done presenting treatment, we would have them in the consult room. They would actually call the financing company directly and arrange for their financing. So really, I was kind of out of it. Cole asked me, once you had an idea of the patient's treatment goals and budgets, would you tend to discuss one main option that you felt was ideal? Yeah, you know, good question, Cole. I did not sit there and get into, you know, writing up 4 different treatment options. I would always I would always have in the pocket what I felt was the best treatment plan and bring that up again with the patient and try one last time if their budget was below that to have them do that. Don't get into writing up 4 or 5 treatment options. You should know by the time you get to the consultation appointment what treatment plan they're going to accept and what their budget is. Otherwise, you're just going to spend a ton of time. Does free consultation include a cone beam? Sang Shing asked. Saying, you know what? If I had somebody that I was really trying to work with, wanted to convince them to come and see me, I often did not charge them for the cone beam. I thought, you know, charge them $400 for a cone beam when I might get a $40,000 case. The only thing I did do with cone beams is if I did not charge them for it, if they wanted to go elsewhere and they wanted that cone beam, then I told them right up front they'd have to pay for it in order to get it and take it with them. But the cone beam helped me answer a lot of questions about, you know, am I going to need sinus grafting? Do they have enough bone to do the case? You know, that kind of thing. Which implants do you like to do, removable or permanent for full arch? Ivan, that really depends. There are situations for both, is what I'm going to say. If you want a more complete answer, why don't you just email me at dramstadt@gmail.com. Either one works. It depends upon their smile line often. It would take a long conversation that I'm probably not going to be able to do. What do you charge per implant? Robert, I was charging per implant about $2,000, you know, right around that mark. In Wisconsin here, that would be a pretty average fee for per implant. Okay, so Cole's back again. In other words, how many options would be the maximum to discuss before you felt the details were muddled by the patient? Good question, Cole. I really didn't give people more than 2 options. It just confuses them. And most of the time they only got 1 option because we had talked about the possibilities and what the other options were, and they had already eliminated them from their bucket list. Usually when we had a consult, we were down to the 1 option and we were just wrapping up the details. I hope that helps, Cole. Kevin asked me, do you regularly use cone beam? And I'm just going to say every single case. In the old days, you know, we didn't have cone beam. I bought the second iCat cone beam in Wisconsin, that baby iCat way back, and I'm just kind of addicted to cone beam. It just keeps you out of trouble, and you can anticipate ahead of time everything that needs to be done. And if you're doing, I'll say this, Kevin, if you're going to place implants immediately into extraction sites, you definitely want to have cone beam before you start doing that. So you know what you're getting into and what you're going to need to do to be successful with immediate placement. I just, again, like to thank everybody. That wraps it up. Feel free to email me at dramstadt@gmail.com. I am available and do a lot of teaching and coaching. I come to people's offices and handhold and educate and help people market and improve their office so they can do more implant dentistry. Thank you all.